Hello, and welcome to my virtual talk on the Orthopaedics of Arthrogryposis. The formal term is really Arthrogryposis multiplex congenita, where arthrogryposis, when you break it down, means curved joint, multiplex means multiple areas of the body are involved, and congenita means present at birth. We call it AMC for short. The definition of arthrogryposis is a congenital, non-progressive limitation of two or more body parts, meaning that the contractures were present at birth. They are non-progressive in that a normal joint cannot become abnormal, and they can't be a single body part but must be more than one body area, such as both the hips and the feet. Arthrogryposis is not a diagnosis of itself, but a descriptive term for a baby born with multiple contractures in multiple limbs, maybe including the spine. The overall incidence is about 1 in 3,000 babies that are born, and more than 400 different conditions lead to a baby born with arthrogryposis. What do all these different conditions have in common? Something called fetal akinesia, or limited intrauterine motion during the fetal stage of pregnancy. Pregnancy is broken up into two stages: the embryologic stage, which is the first 2 months of pregnancy, where the original two cells multiply over and over, building a miniature baby. Then the final 7 months are the fetal stage, where the miniature baby is grown up into a regular-sized baby, ready for delivery. It is during the fetal stage that the joint problems of arthrogryposis develop. What happens is that the baby is not moving enough during the fetal stage, and therefore the joints become stiff. You need to have motions to develop a normal joint, both from the perspective of the bones as well as the tendons, muscles, ligaments, and even the skin. If the skin doesn't move, the normal creases don't develop, and dimples can develop where the skin is adherent to the underlying bone. Other problems that happen with fetal akinesia are related to the fetus not breathing or swallowing the amniotic fluid, which is important for developing the jaw, the digestive system, and the lungs. If the fetus isn't processing the amniotic fluid correctly, too much fluid can collect, called polyhydramnios. Because the babies aren't moving around enough, the umbilical cord can be short since it isn't getting stretched out appropriately. How do these 400 different conditions cause fetal akinesia? Well, there are many different pathways to developing fetal akinesia and subsequently to arthrogryposis. And in some cases, the causes can be intertwined. For example, starting with the nervous system, we look at the communication between the brain and the muscle. So at the highest level, if there are structural problems with the brain, such as an absent corpus callosum, or functional issues, such as the child on the left MRI with perisylvian polymicrogyria, with a normal MRI on the right for comparison, the brain is not functioning appropriately, and therefore no messages are even formed to the muscles. The spinal cord can have abnormalities so that the messages are not transmitted from the brain down to the muscle. Or the peripheral nerves that go from the spinal cord to the muscle may be abnormal. And finally, where the nerve connects with the muscle, the communication may not happen. There can be issues with the muscles themselves, where they do not function appropriately, such as in the distal arthrogryposes or congenital muscular dystrophies. Connective tissues can also be abnormal. The surrounding tissues around the joint in these conditions limit the joint motions during pregnancy, and by hindering the joint cause arthrogrypotic contractures. Not too long ago, the mothers of children with arthrogryposis carried a lot of guilt, thinking that they were somehow responsible for causing their children's arthrogryposis. But those causes are actually relatively uncommon. For example, lack of intrauterine space, where there's an abnormally shaped uterus, such as the bicornate uterus on the right with the normally shaped one on the left. That, or uterine fibroids, can block fetal intrauterine movement. Twins or multiple births can lead to a more cramped environment for the fetus. A lack of amniotic fluid, known as oligohydramnios, can restrict the fetus from moving. The important thing in all these cases is that the restriction in space becomes more evident at the end of pregnancy, and these happen to be more mildly affected babies. Other maternal causes can be infection or medical conditions, such as rubella, rubeola, or Zika virus. Multiple sclerosis, diabetes mellitus, myasthenia gravis, and hyperthermia have all been associated with arthrogryposis. Some prescription medications or recreational drugs have been implicated in causing arthrogryposis. And vascular problems can be an issue. These are situations where the baby is not getting enough blood supply through the umbilical cord due to an abnormal placenta, such as in placenta previa, or in cases of twins, where one twin is getting most of the blood from the placenta compared to the other one. There are many ways to classify the underlying conditions that lead to arthrogryposis. My favorite is to divide up the conditions into three nearly equally sized groups. The first group has only one condition, called amyoplasia, the most common type of arthrogryposis. The second group is made up of the 19 different distal arthrogryposes. And the third group is everything else that has a collection of things such as the Pterygium Syndromes, the lethal congenital contracture syndromes, and those with central nervous system involvement. So let's start with amyoplasia. It's the most common form of arthrogryposis, happening in 1/3 of all cases of arthrogryposis. It is not inherited, but happens sporadically, meaning that it comes about spontaneously. Usually there is symmetrical involvement of the limbs. Sensation is normal in these children, as is intelligence. They are oftentimes very smart. They have decreased overall muscle mass, and the limbs tend to be fusiform, somewhat conically shaped, without the usual landmarks. They can have these spiral indentations that are related to the umbilical cord becoming wrapped around the limbs, usually the legs, such as seen in this intrauterine MRI. In the upper extremities, the shoulders are usually rotated inwards, the elbows can be flexed, but more often are extended, and the fingers and wrists are flexed such as we see here. In the lower extremities, the hips are flexed and rotated outwards in what is often called the Buddha or lotus position. The hips are dislocated in about 1/4 of the cases. The knees can either be bent or extended. By far the most common foot deformity is the clubfoot. The most common pattern of involvement is for all 4 limbs to have contractures. Occasionally only lower extremities are involved, and involvement of only the upper extremities is the least common presentation. There can be scoliosis in up to 30% of the children, and sometimes they can be born with a scoliosis that reflects the position that they were in intrauterally. Why do these children present so differently? It has to do with the timing of whatever caused the abnormalities. Babies begin moving at about 8 weeks of pregnancy, starting from the head downwards, and the right side moves before the left side. So if there is a single injurious episode that happens at about 8 weeks of gestation, only the jaw will be affected. If it happens around 9 weeks, then only the upper extremities will be involved. At 10 weeks, it will be a combination of the upper and lower extremities, and at 11 weeks, it can be only the lower extremities. But if there is a lasting abnormality that occurs during this time in pregnancy, it can affect all of these areas together. Other findings are a midline hemangioma of the face that can involve the forehead, nose, or chin areas. They can have an underdeveloped jaw. In girls, the labial folds may be underdeveloped, and in boys, there are often hernias or cryptorchidism where the testes are still in the abdomen. What's the cause for amyoplasia? We think it has to do with an interruption of blood supply into the baby at this very vulnerable point during pregnancy. This is based on identical twin pregnancies that shared a placenta, and one of the twins had amyoplasia, or cases where mothers suffered an episode of hypotension during early pregnancy. Somewhere between the 8th and 11th week of pregnancy, there is some sort of an accident that happens right when the anterior horn cells begin developing within the spinal cord. The anterior horn cells are a connection between the nerve that comes down from the brain through the spinal cord and the nerve that goes from the spinal cord to the muscle. If the anterior horn cell is damaged or doesn't develop, the communication from the brain to the muscle is interrupted. Now let's talk about the second category of arthrogryposis, distal arthrogryposis, so named because the distal or far end of the limb is most involved, the hands and feet. These are all genetic conditions with autosomal dominant inheritance, meaning that it takes only one parent to pass on the condition, although in most cases the patient we see is the first one in the family to have the condition. The distal arthrogryposes have reduced penetrance or variable expressivity, essentially meaning that affected members of the same family can be affected to different extents. In most distal arthrogryposes, it is the fast twitch muscles that are involved, and these are the muscles that have to do with how the hands and feet work and allow for fine and precise motions of our fingers. The embryonic fast twitch muscles are the ones affected, and these are made very early on in pregnancy. They are actually replaced with normal muscles before the child is born, but the damage to the joints has already been done. Here is a table of the 11 most common distal arthrogryposes with their causative genes next to them. It used to be thought that each condition was caused by its own gene, known as one gene, one condition. But now we know that one gene can underlie multiple of these conditions, And similarly, different genes can lead to the same type of distal arthrogryposis. Likely we'll find that there's more of a continuum between these conditions than we now appreciate. Let me now describe a few of these conditions. The type 1 distal arthrogryposis relatively spares the large joints, like the knees and elbows. It affects the hands where the fingers are overlapping and the thumb is in the palm. And they can have club feet or congenital vertical talus. Freeman-Sheldon syndrome is type 2A and is also known as whistling facies syndrome because the mouth is small and puckered. They have finger and hand contractures as well as club feet and congenital vertical tali. The type 2B is known as Sheldon-Hall syndrome. These patients used to be thought to have Freeman-Sheldon syndrome until it was found that as a group, these patients are less severely affected and don't get scoliosis. Beals syndrome is something completely different. These are tall and thin children, and they look very much like children with Marfan syndrome. Like children with Marfan syndrome, these children can develop scoliosis and aortic enlargement, but unlike those with Marfan, these children have finger contractures like the others with distal arthrogryposis. And this is the third category, the everything else category, which has a number of different conditions, such as the Pterygium Syndromes as seen here. Pterygii are winging or webbing of joints with a thick tissue that crosses and bowstrings the joints. There are many different forms of Pterygium Syndromes, most of which have an underlying genetic cause. Pterygii can affect many different joints and are often very difficult to treat. The abnormally formed connective tissue restrains the joint from moving. The most common Pterygium syndrome is Escobar syndrome. It is caused by a dysfunction of the acetylcholine receptor, an important part of the communication of the nerve to the muscle. If it is not working correctly, the signal from the brain cannot get to the muscle. It is actually very similar to an adult condition known as myasthenia gravis. When we talk about treating a child with arthrogryposis, we know it is definitely a team approach, including most if not all the people on this list, but particularly the parents and the patient. There are many different modalities for treating children with arthrogryposis, including physical therapy, splinting, bracing, and casting, and then going on to surgical procedures, both of the soft tissue and of the bones. For me, one of the major goals is getting children up and walking, but it is also important to remember that walking is not the sole key to success, and some children are not destined to walk. A number of important points to keep in mind when treating children with arthrogryposis. The children are usually quite intelligent and understand what is happening to them with treatment. They are also sensitive to pain. It is not possible to make an abnormal joint fully normal. There is a variable presentation of arthrogryposis with different diagnoses. It is helpful to have an accurate underlying diagnosis, but that is not always possible. Children also learn to compensate, and we do not want to upset a working adaptation unless we can put a joint in a more functional position where the children can learn to readapt to it. I want to note here that we are still learning a lot on how to treat children with arthrogryposis, and much of what I'm about to tell you is based on my experience and learning. And as Will Rogers once said, good judgment comes from experience, and a lot of that comes from bad judgment. And there are no cookbook answers to indicate what we need to do to treat these children. The treatment algorithm I use is to treat the foot deformities as newborns, correct the hip deformities between a year and a half, and address most of the knee deformities after 4 years of age. Starting at the feet, the two most common deformities are the clubfoot and the congenital vertical talus. The goal of treating the arthrogrypotic clubfoot is to have a braceable foot that is flat to the ground and achieving that with the least amount of surgery while preventing recurrence as best as possible. Recently, treatment has become much less surgical, with the recognition that arthrogrypotic club feet tend to recur regardless of how they are treated. If they are treated surgically, their relapses are harder to correct. The Ponseti casting has become a very important modality for treating these feet. The Ponseti method was described for typical club feet with weekly stretching casts. Once the foot was well corrected, an Achilles tenotomy was done, and then the foot went on to years of bracing. The only real surgical procedure needed in the younger children is an Achilles tenotomy, which is often done as an office procedure for children under 1.5 to 2 years of age. There are a few modifications we make for the arthrogrypotic club feet. Occasionally in the very severe feet, an Achilles tenotomy is done early on or prior to the start of casting. Then, after the foot is corrected by serial casts, the Achilles tenotomy is done or redone to bring the foot flat to the ground. 3 weeks later, the final cast is removed and the bracing is started. Here I'm going to describe an Achilles tenotomy. On the left, you see a severe clubfoot that is quite tight in the Achilles tendon. I inject a little bit of local anesthetic on this awake baby. I take a scalpel through the skin and make a small incision to nick the Achilles tendon. Here you can see the small incision that we made, and here is the first cast. It is important to note that the baby is only a little bit more uncomfortable than with application of the other stretching casts. Here are some pre-treatment feet, and here they are after casting, showing the correction we can obtain. In terms of bracing, in the typical child with clubfoot, we use the boots and bars type of braces. But in children with arthrogryposis, this style of brace doesn't do a good job preventing recurrences, probably because the children don't kick very much. Also, because of their hip and knee contractures, they are often hard to fit with these sort of braces. Instead, we'll use a brace like this, known as an AFO, that is cut back around the ankle to allow some flexibility. In the daytime, it is used for walking, and at nighttime, we have put pull straps to stretch out the Achilles tendon. Here is a 3-year-old boy with no previous treatment. You can see he was walking on these feet by the thickened skin or callus on the outside of his ankles. We did an initial tenotomy, then casted him 9 times, followed by a second tenotomy. After 3 months of treatment, we had well-corrected feet. This older boy had had some sort of foot surgery before he was adopted from China. You can barely see the scar in the middle picture, but he had never walked. So we casted him out, and after treatment of his hips and knees as well, he was now a very functional walker with crutches. Clubfoot relapses are common in children with arthrogryposis, but as they get older, the time between relapses increases until finally, somewhere between 6 and 10 years of age, the foot stabilizes and holds its position. Occasionally, we may need to do small procedures on the feet once the child is done growing, but this is much better than doing a large operation on the foot as a baby. What we want to do is avoid what happened to this 15-year-old boy who had multiple procedures done on his foot before I met him, to the point that I can't even name what bones are remaining, and the correction is a very difficult process. There is a second form of clubfoot which we call the equinocavus clubfoot variant. It is different from the typical or classic clubfoot. The foot is much more down-pointing and not as rolled inwards as the typical clubfoot. There's a deep crease going across the bottom of the foot as well as a very high arch. What we try to do with these feet is get them flat to the ground so that they can be well braced. The toe contractures often recur, needing extra treatment. The casting technique is different from that used in the Ponseti method. In fact, if the Ponseti method is used, it will result in an overcorrection deformity, so it is important to recognize these feet early on. Here's an example of an equinocavus foot. After 6 casts, the foot was fairly nicely corrected. The Achilles tenotomy allowed the foot to be flat to the floor. Now we will switch gears and talk about the other common foot deformity in arthrogryposis, the congenital vertical talus. This is often seen in children with distal arthrogryposis and is sometimes referred to as the rocker bottom foot or the Persian slipper foot. What you can see is that the heel is rolled off to the outside, unlike the clubfoot where the heel is rolled to the inside. The front of the foot is also pushed to the outside in comparison to the clubfoot where it is pushed to the inside. Matthew Dobbs came up with a way of treating these feet with casting to avoid the big surgeries we used to do for these deformities. In this casting method, the front of the foot is gradually stretched and molded downwards and to the inside, trying to realign the ankle bone or the talus with the bone in front of it, the navicular. At the end of casting, a small incision is used to realign the talus and the navicular, which are held in place with a pin. An Achilles tenotomy is also needed. With this technique, a foot like this, after a few casts and the surgical procedure, can look like this. You can see the small surgical incision on the inner side of the foot. Now let's talk about hips. Typically, the earliest that I will address the hips is between 12 and 18 months of age, when we look to correct the hip contractures or dislocated hips. Hip contractures tend to be flexed with the hips turned outwards and the hips spread apart or abducted. In some cases, there's only a flexion contracture like you see here. A small procedure called an anterior hip release can be done through a 1/4-inch incision where the tight fascia or scar tissue in the front of the hip can be loosened, allowing the hip to be extended. Often though, the hip contractures are not only the flexion contracture, but also an external rotational contracture and severe abduction. In these cases, the reorientational osteotomy is a very successful treatment. The object is to leave the ball of the hip in its current position within the socket, but put the rest of the leg in the best position relative to the body. This puts the knee pointing directly forward. This little girl provides a good example of how the procedure is done. This is how she lay on the operating room table, and an x-ray shows the positions of her hips. Her hips could not be brought down further from that position. In the procedure, the thigh bones, called femurs, are cut just below the hips, and the legs are brought into alignment with the rest of the body. The bones are held in place with this question mark shaped metal plate until they heal. There she is directly after the operation, and below is how her hips looked several years later as the bones remodeled into more normal appearance with growth. And here she is lying down on the examination table and standing up and walking. The other common hip problem in arthrogryposis is a congenitally dislocated hip. The traditional thinking was that if only one hip was out of joint, it could be surgically relocated, but if both hips were out, they should be left out. That was because of the concern of the hip stiffness developing after surgery. But we found with our patients that the congenitally dislocated hip have some stiffness prior to surgery, and it does not get worse with the surgery to relocate them. Studies have also found that adults with arthrogryposis walk better if their hips are relocated. A common concern we have heard is that the hips have no sockets, but we have always found a socket at the time of surgery where we can place the ball back into. This young lady is a nice example. We corrected her clubfoot with casting and afterwards relocated both her hips. The pictures from her family show that there's little that holds her back. Now we will switch gears again and talk about the knees. The knee deformities can either be knee extension contractures or knee flexion contractures. The straight knee is a problem with sitting for the older child or adult, whereas the flex deformities make walking very difficult. First, let's talk about the knee extension contractures. In general, these children do better with walking early on. But between 6 and 10 years of age, the straight knee causes difficulties with sitting, such as in cars, buses, and airplanes, so it becomes important to get the knees to bend better. In a few cases, the contraction could be so severe that the knee actually bends backwards. The extended knee contracture can be treated early on with serial casting and Botox injections, but many will require extensive surgery and bracing. When treating the knee extension contracture with casting, it is really important to know where the knee is pointing, because the hip contractures will almost always make the kneecaps point directly out to the side. If the person doing the casting assumes that the knee is pointing straight forward, then instead of bending the knee with casting, the ligament on the inner side of the knee is stretched out, resulting in a difficult knock-knee deformity. In these pictures, the smiley faces are over the kneecaps, showing how previous casting caused the knock-knee deformity. In the older child, a large soft tissue release may be necessary by lifting the quadriceps muscle off the femur and lengthening it. Sometimes it is necessary to shorten the femur to increase the flexion. Flexion contractures can be treated in a few different ways. An attempt can be made to stretch them with casting or braces, but in my experience, this has limited effectiveness. Sometimes it is necessary to loosen the tissue behind the knee in conjunction with other procedures, such as slowing the growth in the front of the knee to fake a straight knee. More severe contractures need to be treated with realigning of the bone or stretching of the knee with an external fixator. First, let's talk about what's called a hemiepiphysiodesis of the growth plate at the bottom of the femur. By tethering the growth plate or physis in front to slow its growth in front but allow it to continue to grow in back, the bone slowly angles over time, making the knee straighter. This works well with contractures of 40 degrees or so. If you look at the growth plate from the side, you can see how it progressively angles from immediately after surgery to about a year later, which allows the knee to become straighter. The more severe contractures, which are contractures over 40 or 50 degrees, can be treated either with an extension osteotomy, which means acutely angling the femur through a cut just above the knee, or by gradually stretching the knee using an external fixator. This is what an extension osteotomy looks like by cutting the femur just above the knee and realigning the bone to make the knee appear straighter. Such as in this teenage boy here. We left a little bend to his knees since he didn't have much motion altogether in his knees. We wanted to leave enough flexion for sitting. He walks quite well this way, but this is an operation that is suitable for children who are done or nearly done growing. Here's a case of a child who had the extension osteotomy done at an early age before her first birthday. By 2.5 years old, her growth plate remodeled itself back to its original position and the knee contracture completely relapsed. Instead, for growing children, I'll use an external fixator, which uses pins going through skin into bone. The pins are connected to a frame, essentially rings around the leg with hinges at the knees. The frame is gradually adjusted at home over a month or two, resolving the severe flexion contracture by stretching out the knee. As an example is this young man here. We corrected his feet with clubfoot casting, then repositioned his legs with reorientational osteotomies of the hips. Here he is up walking with his KAFOs despite his severe knee flexion contractures. After 4 years of age, we straightened his knees with the external fixators. We were able to get both knees straight enough that in time he was able to walk with AFO braces. I want now to talk about scoliosis before I run out of time and Michelle pulls the plug on me. The curves can happen at any time during the growing years, but many children are actually born with curves, which reflect their position in the womb, where they were unable to move themselves. We call these neonatal curves. They seem to stay stable for a number of years, and it still isn't clear to me if bracing or casting the little ones makes much of a difference in the long run. Here is the boy from the previous slide. His curves stayed stable until he reached puberty, then progressed to the point that he needed a spine fusion. Treatment options for scoliosis and arthrogryposis include physical therapy to strengthen the spine and keep it flexible, casting or bracing the spine to diminish the curve or just prevent it from progressing, and surgery. In growing children, we use an expandable implant to keep up with their growth, whereas in the skeletally mature patients, a formal spine fusion is performed. This child underwent spine casting from 2.5 to 4 years old, with a curve reducing from 40 to 22 degrees. This young lady had her curve stabilized with a brace until she was old enough to have expandable implant surgery. This 5-year-old boy had an expandable implant placed for a severe curve. If you compare the rods in the middle picture to the far right picture 2.5 years later, you can see how the rods have telescoped, elongating them. And this is what a formal fusion looks like for this fully grown girl with a severe curve. After the surgery, she was able to sit much more comfortably in her wheelchair with her pelvis level. Thank you very much for watching this presentation. I also want to thank all my patients who have taught me so much over the years. Their stories will always inspire me. I am truly sorry that we couldn't do this talk in person, but I look forward to the meeting next year so that we can.